So I welcome Namrata, Dr. Shukla sir, Jyoti, and this is the session sponsored by the INTAD. So I am thankful to INTAD for the such important session. Dr. Kishore Masurkar and Nikhil Masurkar, they are doing very good work in the this all the pharmacology or in the can say in the as a company. So now as Praveen is yet to come, we will go to the Suma. Suma Ganesh is going to speak to us on role of atropine eye drops in management of myopia. Dr. Suma Ganesh.
Good morning. At the onset, I would like to thank Dr. Namrata ma'am and the scientific committee for inviting me here. It is indeed a privilege to speak about myopia, which is now a growing concern among children and also among adults. So I'll be talking about halting myopia progression with atropine. So I didn't do the epidemiology part because thinking Dr. Praveen Vashisht will be doing that part. So I'll be straight going to the progression of myopia. I think sir will speak later. So the annual rates of progression of myopia, we know that it is inevitable, and the rate of progression is 0.15 diopters to 1.2 diopters per year. And it is mostly seen in younger myopes, more myopia at onset and due to ethnicity. So why do we fear myopia progression? Because we find that the risk of ocular pathology is mainly seen with high myopia. The risk of retinal detachment, we find that the odds ratio, when the higher the myopia, we find that if it is reaching up to -7 to -8, it is around 44.2% odds ratio. So this is not very good. So we need to halt the progression to at least, if we can halt the progression in children, not progress it beyond high myopia. So we have to counsel parents, because parents are still skeptical about putting any drops or wearing any glasses for the control of myopia, because they don't see the long-term risk. Like if you see a 4-year-old child with a -3 diopters, and if it is a 0.5 diopter increase per year, then we'll have -8. So at least we can keep it at 14 years, it is -8. So this is the progression which we still don't want, but this is what is inevitable sometimes. But if it is a 1 diopter increase per year, then we find that at 14 years, it may be -13 diopters. So this is what we have to counsel parents, because they think at the age of 4 years, 3 to hai, and then every year they come that, okay, 1 diopter increase. But we have to give them the long-term picture, why we are afraid of this myopia and why we want to tackle it early. So my topic is on atropine. So there are many methods of halting progression. Nowadays we have we have low-dose atropine, pharmacological method. Then we have the myopia control glasses, where many companies have come up. There are 3 companies which have come up with these glasses. We have orthokeratology, which again another speaker will be speaking on. And then we also have contact lenses. So we have for contact lenses for progression, for halting the progression. So I'll be speaking mainly on atropine. The exact mechanism is not known, but it is said to block the muscarinic receptors non-selectively. So it is believed that atropine acts directly or indirectly on the retinal or the scleral, inhibiting the thinning or the stretching of the scleral, and thereby the eye growth. So through the M1, M4 receptors in the retina, it is said to act not on via the accommodation system. So the ATOM studies were done, and this was published. So first in 2009, the atropine just for the treatment of childhood myopia. In this, the study done was just with 1% of atropine. Later on, they did another study, ATOM2 study, where they studied with the safety and efficacy of 0.5%, 0.1%, and 0.01%. In that study, the 0.01% was actually the placebo group. But what they found in the study was that all the 3 doses had the same response to progression, and that is how we found that that atropine 0.01% is as safe and as effective as atropine 1% with lesser side effects. And that is how, after the ATOM2 study, which has been done for 5 years, it is concluded that atropine 0.01% is effective in the treatment and in the halting the progression of myopia. So 0.01%, only 24% progressed in this study. The atropine, the safety also was, safety they studied was seeing whether the child had any problems. The pupil size was small, and also they found that did not have any blurring of vision. So let us go to different case scenarios, because what we want to know is that if in an 8-year-old child, if they're presenting you with myopia progression of 0.75, what is the treatment of choice, and what investigation should be done? Now the audience, I wanted some interaction from the audience. So basically, when a child comes with a progression of 0.75 and you want to give treatment, so there are 3 options. Now what is the treatment of choice? So what we go is, first we find that what is the axial length. So we should do the axial length in all myopia children and find out it is progressive, whether it is the axial length only which is responsible for the progression. Because only the atropine 0.01% drops will have an effect only if it is due to the increase in axial length. So it is important for us to check the axial length. So this is the investigation which we need to do. RP Center group, and we had a childhood myopia group and workshop, and in the multi-centric randomized trial also, which was done in the Indian population, we found that atropine 0.01% worked, and this will be the treatment of choice. So the next case scenario is the patient has been on atropine on LDA 0.01% since 1 year, and again it has progressed to 1.5 diopters. So now, how do we go ahead, because the parents are complaining that again the progression has occurred. I have put atropine 0.01% for 1 year, and still there is progression. So then we can do combination therapy, like where we can offer the patients another modality of treatment is that we can give them low-dose atropine. Along with them, we can add a myopia control glasses, like Stellest or MyoSmart or Zeiss lenses, Zeiss glasses. These are available, and these are helping in halting the progression of myopia. Or we can even, if we find that, so what they studied was, which is the LAM study. I will explain in detail about the LAM study. So the proposed strategy in your clinic will be that you start on 0.01% atropine, and every 6 months you check the refraction and also the axial length. And then if there is a stable progress, you continue it for 2 years. And after, suppose now, if it is still progressing within 2 years also, then you can either switch to, with the LDA, you can switch to orthokeratology, or you can switch to, you can start with the myopia control glasses. And the next concentration which we'll be talking about is whether we can switch to the other concentration of atropine. And then if we find that we have continued it for 2 years, and then we stop it for 1 year, and then what happens after 1 year after stopping? If it is stable, then it is good. But if it's again progressing, then you can restart your atropine 0.01%, and you can give it up to adolescence. So you can give it up to the teen years, and you encourage your outdoor activities. You tell them that you need to do more outdoor activities, or you can also do combination therapy. So the combination therapy is working much more if the child is still progressing with low-dose atropine. So the LAM studies were done, phase 1, phase 2, and phase 3. And the LAM study, they studied 0.05%, 0.025%, and 0.01%. And now the 3rd year is being completed, the phase 3, which they gave a report on 2022, they are published. And they found that 0.05% atropine remained the optimal concentration over 3 years in Chinese children. We were just discussing with Entod, who has sponsored this session, and they were saying that they are coming up with this dose of 0.05% very soon. And the LAM study has shown that this is more effective than 0.01%. So the side effects, but with 0.01% are very less, so we can give in all patients. I have just had 1 or 2 patients who have complained of blur vision, even with 0.01%, but that compared to the large number of children, we find that it is very less. So I will talk of the last case scenario. There is a 3-year-old wearing myopia glasses, single vision glasses, and it is -3 diopters. So, what is the next? Should we start on atropine eye drops in a 3-year-old, or we should not start? So we find that everybody is still starting on atropine eye drops. It is advisable that there are no studies being done in this age group for the atropine eye drops. We should not give in such children, observe, and we should just give the single vision glasses. So the scenario where we find that very high myopia is mainly with ROPs. We find that the parents are being advised to give atropine low dose, but remember that this ROP associated high myopia is mainly because of lenticular causes. So, and atropine low dose is not going to have an effect on these children. So we have to know the cause and the effect. So for eyes with myopia, so we find that if it is because of the axial length elongation, then it is right to start on atropine low dose. But if it is because of the lenticular changes, please don't start atropine. It is not going to work. And also in very high myopia in infants, we find it is rare. It is less than 1%. So if you find a high myopia in very preschool children, say in less than 5 years, please investigate for the other causes. It is not common to see high myopia. So you may have to rule out if there's any Stickler syndrome. So it is better to evaluate them. It could be in a Down syndrome or other cases of retinal disorders. So please do an ERG, electrophysiological test, and also do a pediatrician and a geneticist involvement. So so ocular image, electrophysiological test may be an additional thing when you see high myopia in very small children. I think this is the end. You can continue? Okay. So then the next scenario is a child, I'm just putting the cases because all these problems come to our practice, clinical day-to-day practice, and we don't know what to do. So now there is a child with a -6 diopters, and there is a squint also associated. There is an intermittent exotropia, distance and near 30 prism. So now what to do? Whether we should give atropine low dose or whether we should give the myopia control glasses. So myopia control glasses are not going to work in such children. So we need the low dose atropine will still work, and there are studies which have been done. And now there's a both situation where you have a high myopia, where you find that the demand of accommodation is more, and therefore the child may go into exo. And you can also have a child with exotropia, where the child has already problems with accommodation, and you can develop exotropia. So in both the cases scenarios, where you have to do is that, what should I do first? Whether I should control myopia or whether I should go for a exotropia surgery. It is ideal to go in for a exotropia surgery and then keep the child controlled on atropine drops, or you can put the child on myopia control glasses. So it is important that we control the exotropia. We can do surgery in these cases. And so, but you have to avoid atropine whenever it is because of any cone dystrophies, or if there's any potential cardiac complications or a syndromic myopia. So always try to evaluate the cause, and please don't start myopia, the atropine eye drops for any patient. So it is effective, but we have to see in which patients we need to start. Basically in age 4 to 12 years with documented progression of 0.5 diopters in the preceding year. And we can continue it for a longer period of time, though the atropine study has been only for 5 years, but we can continue. So basically we need to have good eye care habits, enhancement of time outdoors, and limiting near workload should not be also overlooked. Thank you.
Yes, sir.
Yes, sir.
Yes. So those we are not putting, yeah. I didn't do any study. I'm just saying that we should not include, we should look for these causes, the syndromic causes or the retinal dystrophies. We should look if. So we have to.
Genetic myopia, he want to say.
Yeah. So in genetic myopia, suppose if there is a genetic cause, and if the cause is because of an increase in axial length, you can still put atropine. But unless, suppose if there's a cardiac problem associated, like suppose if in a Marfan syndrome, then I would not put atropine. So you have to be careful.
Yes, Shukla sir.
Can I comment on? ऐसा है sir कि see, it's not only purely genetic. See, we have 200 genes. We are directly or indirectly associated with myopia. 26 genes have been marked, which are directly related to myopia. But it is not only the genetic. A lot of environmental factors are affecting. So, sir, pure genetic कुछ नहीं है अभी. No, there are so many things. बहुत सारी चीजें sir. There are so many things. Not. No. Genetic is one of the causes. Triggering fact तो genetic है sir. That trigger. नहीं आप मेरा मतलब समझिए. You see, the triggering factor is genetic. I mean, it is genetic, but it has to be triggered by environmental factors. Okay. And there are so many environmental factors which have been now studied. There are almost 100 papers on that in the last 1 decade, yeah. And, sir, near work hai, continuous working hai, the length of work hai, you know, and your accommodation hai, you see, smoking bhi hai. There are so many things, you know.
As so we'll ask the delegate, see what is the, why this discussion we are doing. Atropine is very important in myopia. And nowadays if you see, all the practitioners, when there is a myopia is seen, they are going for the atropine. So I want some delegates to ask their queries, and then we will discuss it in the, amongst the yes. Yeah, there.
I actually wanted to ask that most of the times what I am seeing is there is a child who has myopia. He has been seen by the doctor for the first time. They gave him the glasses and at the same time they start him on the atropine eye drops also. I mean, I'm seeing it very commonly. I mean, should we discourage this practice?
No.
What,
No, it is. See, I'm very much, you know, affiliated with the myopia treatment. I'm the incoming president of the National Pediatric Society, and the entoured people we are doing in our annual conference of the pediatric ophthalmology. They are doing a full session, a 2-hour session of it. You see, you have to give glasses. See, one thing you should remember, that any child who develops myopia, what am I the reason? Because before 5 years is a progressive myopia. So you have to deal with it as a progressive myopia. And you have to give specs, otherwise, you know, he can't see otherwise. If there is -4 or -3 in a 5-year child, how are you going to go to school? You see, so the basic is specs, there is no doubt about it. But then, the specs are not controlling the progression, you know, specs are only as a palliative treatment. Specs sirf nazar ke liye hai. But what about the progression, how to suppress or how to curtail the progression of myopia? For that, we have now number of drugs, you know. And so far, the atropine 0.01 and 0.05 have been found to be the most effective. Though we have pirenzepine, 7-methylxanthine, if in children 7-methylxanthine is very effective, more than atropine. So it's very safe in children. So, you know, you have to compensate it with not only low dose atropine or pirenzepine like that, but also the environmental factors. You see, there is a big research, you know, we don't have time, it has to be a full session for that.
This is not her question. Question is that when the patient comes to the clinic, patient is having the myopia, the first visit only they are starting the atropine. So they should start the atropine on the first visit, or they should see the progress, that the progress is 0.5, and because of that we are starting the atropine. So instead of starting the atropine to begin with, we should wait, see you can both axial length and also the increase in myopia. So Namrata, what is your this one in?
So I think Suma shall be able to answer this question, but
So
I think that if the axial length is increased, then how is atropine going to affect on it? I think that part the atropine cannot take care of.
So basically, what we are saying is that when the patient comes initially only, and with suppose with myopia, only when it is documented progression, say in the next visit, then we are starting. At least that's what we are practicing. We are not starting atropine in the first go. Okay?
How much should be the documented
so then
increase?
we have to, then
How
we'll
much?
document. So that what the investigation, what we are going to do, we are going to document whether we'll do the axial length. We'll do, like suppose the pentacam also nowadays we are doing, so that we have the baseline what is there. And then we are seeing what is the progression. So next 6 months we'll call the patient again. And then if we see there is an increase in the axial length, and still we don't know whether it is, so like studies have not shown that it is atropine, like how Dr. Ma'am is saying, Dr. Namrata Sharma Ma'am, that whether it is directly affecting, but studies have shown that it is basically the atropine is affecting the axial length, halting the axial length progression only. It is not affecting on the accommodation part at all. So we can give it safely in children whose axial length is progressing. And when we have a documented axial length progression, then we should start atropine.
No,
To add to what Dr. Lahane is saying,
So when
Yes. How
basically if you are looking at anything more than 0.5 diopter increase in your refractive error per year, or a 0.3 millimeters of axial length per year, then we are looking at it.
No, we say every 6 months, not
No,
yearly.
every 6 months. But if the progression is showing, suppose in the 6 months it's remained stable, but when he comes back, so when you are documenting anything more than 0.5, nevertheless, if there is a parental history, there's a brother history, you see that the patient's lifestyle is he's a voracious reader, so you have to look at multiple things.
Yes.
But a documented thing is 0.5 per year and point. But we call them every 6 months. Every 6 months refraction is done. Every 6 months axial length is checked. So we know and we monitor this. That is important. But over and above whatever you're treating, lifestyle modification is extremely important. Which means outdoor of minimum 2 hours. Reading, writing should be at 14 inches. Follow the 20-20-20 rule. And whatever it is, take breaks. So this is something you have to keep on telling in addition to whatever treatment you give to them.
Basically, I think in the discussion, what is happening when patient is coming of myopia, we all are starting the atropine. So that should not be done. Minimum wait for 6 months, see the progression is 0.5, our axial length is increasing. It means myopia. Why we are doing this? Myopia is progressing or not. If it is progressing more, then only we will have to arrest it by the atropine. It is not only one drug, but other drugs can be there, but arrest. And about the percentage, she has already told us that this type of percentage we should give. This 0.01 we are giving, 0.05 is better. That is lamp study, but it is not that entire would prepare it or manufacture it. But when patient is coming first time, don't give myopia. The second question to Suma, how many years we can give atropine?
Yeah. So I've already mentioned, but I'll explain again. So basically, till now the ATOM study was done, and it was done for 5 years. No? So 5 years they have done the study, and even LAMP recent study they have done it for 3 years. So basically, you are giving, how we give is, we give it for 2 years. Okay, then stop for 1 year. But in that 1 year, you are going to follow up the child every 6 months. So now if you find that when the child comes to you after 6 months, after you stop the atropine drop, again it has progressed, then you can continue the drop up to your teens. That is what the recommendation.
18 years. You
18,
can
16 to 18 years, you can
continue
give it
up
up
to
to safely.
Very true. Now see, practically, the atropine should be started for 2 years. One, dictum. Stop it for 6 months. If progressing is there, again start. And then you can go up to the 18 years also. But always stop after 2 years and see, give the gap of 6 months and then go for the, if required and progression is there, then you can start the atropine. And now, thank you, Suma. I think it was a very important topic, so we discussed. And now none other than our scientific committee chairman, really I appreciate and congratulate for the excellent scientific feast here in the midterm AIOS, Dr. Namrata. She is going to speak to us on the refractive surgeries for myopia, as she has other sessions, so she is just presenting us. Dr. Namrata, please.
Thank you, and I'm sure there are going to be great discussions and deliberations, but I'll be just telling you about how to manage adult myopia with the refractive surgeries, and this will be again followed by contact lens, orthokeratology, and management by spectacles. So I think type of refractive surgery is important. It could be cornea based or lens based or bioptics, which includes both. And dilemmas are not in doing the surgery. I don't think there's too much skill involved in the surgery. Dilemmas are, is the patient suitable for refractive surgery, and which surgery is best for the patient. So the FDA has given very clear guidelines for surface ablation and LASIK. It is -10 dioptosphere and 4 cylinder. And as far as hyperopic is concerned, it is +4. For SMILE, it is up to -8, and now even up to 2.5 diopters of astigmatism. And phakic IOLs is as shown -3 to -20, and +3 to +10, and 6 diopters of cylinder. And refractive lens exchange possibly can be done for all ranges. So the ideal candidate, you do need that the age should be at least 18 years. For SMILE, the age is, for lenticular procedures, it is 21 years. For ICL, 21 to 45 years. And for PRK, again, at least 18 years. So the ideal candidate would be a person who's had a stable refractive error, less than 0.5 diopters change in past 1 year, no, not pregnant or breastfeeding, no systemic or autoimmune disease, adequately counsel, and no ocular comorbidities. Absolute contraindications are, of course, ectasias or those who have a propensity for ectasia, and relative contraindications are many, like dry eye, herpes infection, etc., and is left to the discretion of the operating surgeon. It is important to do a good ocular examination, but I think it is very important to do this clinical investigation, and more so the corneal pachymetry and the corneal topography, as well as wavefront analysis if required. And there are at-rest corneas, so if you have a keratometry which is high, or if you have inferior superior asymmetry, or if the corneal thickness does not allow you, it is less than 470 microns with normal topo, or less than 500 microns with abnormal topography, and anterior elevation and posterior elevation likewise are more than 12 or 17, then one can't do refractive surgery. Bell-and ratio enhanced display is also important, and the difference map, again we look at the band and also the progression, the thickness profile, and the progression in terms of the bad values. Now, which surgery is most suitable would depend on residual bed thickness, corneal thickness, and the steepness of the cornea. And this is basically the guidelines. So if the thickness and the keratometry allows you, then you can do cornea-based procedures. If it does not, then you have to do the lens-based procedures. And again, higher order aberrations, if it is less than 0.3 micron wavefront optimized LASIK, more than 0.3 micron wavefront guided LASIK, or topo guided LASIK has to be done. Now, just to give case examples, 21-year-old female with residual bed thickness which is more than 300, with keratometry which is optimum, tissue ablation which is less than 40%, and a topography map like this, one then has to see the pupil, the thickness at the pupil center and the apex of the pupil, and the difference between the pechy apex and the thinnest location is 17 microns. So if it is more than 10 microns, it is significant. So in such cases, if you look at the bad also, you have a red and a yellow value here. And these are the cases where you would like to observe and reassess for stability of the topography after 6 months. Now, case scenario 2 is you have a simple refractive error with the thinnest pachymetry of 550, 555, which again allows you, and keratometry also, which is allows you to do the refractive surgery. But the patient is from armed forces, and in these cases, we would rather plan a PRK rather than a LASIK surgery. And I think there is nothing too much to PRK. We all know how we do it. The alcohol debridement is done first, followed by the laser ablation, and then subsequently followed by the bandage contact lens application. We can also do a transepithelial PRK where the laser itself does the removal of the epithelium as is shown here, and then subsequently the laser ablation is done and BCL is placed. The case scenario 3 is this, where 24-year male for cosmetic purposes with -4 sphere and -1 cylinder. Thinnest pachymetry also allows you to do it. Keratometry is fine, and then one can plan LASIK. But this is a case in which the residual bed thickness is with 110 microns is good, but if you look at the residual bed thickness with 100 microns, the percentage tissue ablation allows you to do it. It does not allow you to do it. Then in those cases, it is best to plan a flap which is thinner, because you know that the residual bed thickness would be greater, rather than a 110 micron flap which will eat away 10 microns more. So I think again LASIK is a procedure which is known to all of us. You can use a microkeratome, which is now almost very few people use it. And after creating the flap, the laser ablation is done. And then the flap is again reposited back. Now this is a case scenario 5 again where RSBT is good. The percentage tissue ablation is also good. The thinnest pachymetry is 512 and 506. So here you can do both the procedures, either femtosecond LASIK or SMILE, that is the lenticular procedure. This is a case where we would want to do a SMILE procedure because this patient is a football player and rest of the parameters are allowing you to do the surgery. But the only fact that the occupation is different, so you change your procedure. Now this is case scenario 7, where again being done for cosmesis purpose, but notice that the Shermer is a little less. So in this case again you would start for lubricants and will possibly do a smile surgery, because that causes a less amount of dry eye. So I think again everybody knows how the procedure is done. The lenticule corresponding to the refractive error is taken out, and this is how the myopia is being corrected. The last is the phakic intraocular lens for high grades of refractive error, and again in this the phakic lenses are available. One can use any company that one wishes to. This is the ICL which is being implanted for the high amplitude of refractive error. And again, this is a simple surgery to do. But I think more important is always the decision for the surgery rather than the simplicity of the surgery. And this is the next case scenario 8. Again, high refractive error. The RSBT and percentage tissue ablation does not allow you to do, so you plan for ICL. This is yet another case where the refractive error was -8 with -1 cylinder, other eye was -3. I would rather do a ICL both eyes so that the quality of vision is similar in both the eyes. This is yet another case where RSBT does not allow you to do surgery, and post-op also is going to become very flat. Refractive error is very high. So you may plan to do bioptics, that means LASIK as well as phakic intraocular lens. And again, this is an example of bioptics, which some people may or may not want to do. Bioptics is again a surgery which is really not very popular. Again, in case where in a patient who's nearing, I shouldn't say old age, but may have cataract in future, can be counseled for other procedures as well. If you have pure cylinder, then one has to be careful, because if the Kmax is high, then these are the patients who may go into ectasia, and ablative procedure should be avoided. And again, in this case, both eyes ICL, because RSBT or residual bed thickness does not allow you to do so. So I think refractive surgery has evolved significantly, and like I said earlier, the decision is more important than the surgery itself, because the patient also needs follow-up frequently in the post-op period. So thank you very much for your kind attention, and I would like to invite all of you to Asia Pacific Academy of Ophthalmology next year in Yashobhumi, Delhi, April 3rd to April 6th. Hope to see you everywhere, everyone there. Thank you so much for your attention.
Thank you, Namrata. It was, I think, everything with indication and everything she has told us. Any questions from the audience?
So if you feel like removing it, or for any other untoward incident you have to remove it, then in that case there are two options. One is you can let the ICL remain in the fellow eye and use a contact lens in the eye from which the ICL has been explanted, provided that the lens is clear and the cornea is clear and that sort of a problem is not there. Second option is, again, that option you have to give it to the patient if the patient wants the bilateral explantation of the ICL. But from the surgeon point of view, I think we should try to rehabilitate the patient with sir, with the current phakic intraocular implants which are available, it is said that they don't get it earlier. It is possible. So when they get cataract, we can explant the ICL and then do the cataract surgery. There is no problem with that. It comes out very easily. It's like a. Thank you, sir.
Dr. Namrata, just one question. Just one, have you, the research going on and the studies, have you tried to do, because higher myopia maybe -12 or 18 you can't do, do you do partial LASIK also in that cases, and then you can specs, for example, how much is the maximum according to the patient, the corneal thickness and the amount of myopia?
So the maximum I think that you can correct as per the FDA is -8 diopters, but From what I understand, sir, you are saying that do you undercorrect these patients
No,
with the refractive surgery?
What I mean is -12 and the patient, because a lot of people refuse -12 mein you can't have LASIK. But can we do some partial, because a lot of patients were asking कि सब कुछ तो चश्मा कम हो जाएगा, you know, like that. So because
So then we, of course, have to counsel
because
them.
high myopia -12 you reduces 3 lines of vision because you get you know the vision goes less because of the high minus lenses. नहीं,
No, that is because, sir, at least
वो
so
वही आ गई
many
ना सर
years
बात,
of
-12 है, -13 whatever it is, -12 का चश्मा लगने से
so as such, for reducing the thickness of the glass, we cannot propose LASIK and should not propose LASIK. But if the patient is extremely motivated, you may counsel the patient that the spectacle independence will not be there.
because you know but these high minus मैं about 10 की बात कर रहा हूँ, you know you have a lot of prismatic effects and you know lot of vision, the acuity goes down, so lot of people are asking कि साहब ये मोटा चश्मा हट जाएगा क्या? So
then
-5
I
भी अगर रह जाता,
I would rather counsel them for contact lenses
no,
than for doing
वो तो they are not ready for contact lenses. वो बात है,
then if the
contact lens हो तो
patient-
कोई फिर तो कोई बात ही नहीं है, then
Sir,
there is
if
no
the
problem,
patient,
you know.
Sir, in my practice, I don't think, I mean, I must have come across only 2 or 3 patients who would have said like what you're saying. But then I would counsel them and do it. But I do not remember having done it for anybody like that.
वो तो सर 100% तो कुछ
So
नहीं ले
spectacle
सकते.
independence is only for the period till the time you are not presbyopic. -6 after LASIK has
Plus.
नहीं 1 आई या both आई सर? हाँ तो फिर तो क्या प्रॉब्लम है, स्पेक्स लगा ले +4 में कोई दिक्कत नहीं है.
No, sir, we have to also look at the keratometry value in these cases because
Yes.
-6 means you are going to make the patient flat and +4 means that you are going to make the patient steeper. And hyperopia, you don't correct more than +4 because for every diopter of hyperopia, you are increasing the steepness by 0.75 diopters. So, yeah, so if you have a patient who has got 44 diopters of K and you do +5 hyperopia, you are actually making him almost 49 or 50, which means you are inducing ectasia. So that is why hyperopia more than 4 you never correct.
Namrata, last question. You have told about the age, what time, we should do. So we should wait for the progression of the myopia to stop, or we can do in between the LASIK surgery or any other.
No, so if we are very stringent with this that the refractive error of the myopia should be
Stable.
for at least 1 year and the age of the patient should be more than 18 years.
The another question is, can we do the LASIK surgery in pediatric?
So there are reports, I think Dr. Yogesh Shukla sir would be able to answer that better, but there are reports because of the amblyopia or anisometropia, if it is there between the 2 eyes, then people have done it and also done it because they fear that amblyopia may occur. So
But the problem with the
Basically, Shukla sir, Namrata madam, there is no any reference anywhere. Now,
नहीं, there are references sir.
There are studies, sir.
There are
There
lot
are
of
very
studies.
small case
They have
series.
tried in 10 years, 12 years में भी उन्होंने किया है, but the myopia progressing too much, and they have tried to do. But the problem is the corneal anatomy and the corneal physiology is so different in a child, you know, because that's why we wait for 18 years. So it's so different that the reactions of LASIK have been a lot of problems, lot of haze, and you know things have happened. So they are not doing because we have other ICL, we have ICL.
it means
Now
in
it has
pediatric we should not do. Why I have asked, I will tell you. The case is going on in the court. The myopia is corrected in both eyes at the age of 9 years in 3 children. And we are answering, but see there is no any, can say, reference, proper reference that where the court will be satisfied for that. But I think we should not, I think, do the such type of thing in the pediatric, because whatever, हाँ वही प्रॉब्लम होता है, तो we should not
experimental है ना sir, it is
हाँ,
still
so we
experimental.
should not do
So,
such experiment on the pediatric cases. Thank you, thank you, thank you, Namrata. The Namrata has got the another talk at the other place, and the other place. See. So I will now invite Dr. Jyoti Matalia, and she is going to speak to us on spectacles. How can they prevent myopia progression? Dr. Jyoti.
Should I go there? Thank you so much, AIOC and Dr. Nahane and everyone here. I'm going to be talking on importance and optical therapy. So let's look at this particular chart. It talks about the global prevalence of myopia and high myopia and the temporal trends from 2000 to 2050. And you can see the initial figures are about when it was. So in this you can see the East Asians had the maximum, and we know that the Chinese population had more myopia than unlike the others. But as you see, the trend is moving on, and eventually we were going to have 50% of the population becoming myopic, which means 1 out of every 2 person is going to get myopic, of which 10% are going to have high myopia. So this is a very, very serious issue, and as we came out of a COVID pandemic, we are surely going into a myopic pandemic. Hence, it's important, and that's why everybody's talking about the various myopia control. But as I said, most importantly, what we have to look at is a lifestyle modification. Whatever we treat, we have to keep on telling the patients, reinforcing every visit, the lifestyle, which is very, very important, because that has completely changed to what was about 20 years ago. So with this, I'm Dr. Jyoti Matalia, and I'm going to be talking to you on the optical therapy in myopia. So what are the various theories of myopia progression? Yes, the feedback which causes emetropization, because of which the eyeball may grow, the dopamine and the scleral biomechanics, the accommodation lag theory, and most importantly, the peripheral refraction. So this is what is about the peripheral refraction. So when you see, normally when you wear glasses, the center part is focused on the retina. But if you can see peripherally, this gets focused behind the retina, that is a hyperopic defocus. And with that came the concept of the defocus devices, where the peripheral part gets focused on the retina, and hence the eyeball will not grow. So what it brings us to our understanding that what are the various options. So one, we have the glasses, that is the peripheral defocus glasses, and the other are the contact lenses, which are there. So what are the, therefore, let me summarize the treatment options, the glasses and the contact lenses. In glasses comes a single vision with undercorrection, the progression addition adds, and the defocus or contrast alternating. In terms of contact lenses, we have the rigid contact lenses, or the orthokeratology, the soft bifocals, or the multifocals. Now we are very clear that the single vision glasses with undercorrection or progressive addition lenses is no longer used. They do not help. In fact, they can cause progression. That leaves out with the other ones. And now I will take you to each of these individual aspects of spectacle options. There's a very good article which is by the Myopia Profile, which you can go through, which tells you in details how they work. So first we have the defocus incorporated multiple segments, or DIMS, by Hoya. We have the highly aspheric lenslets, that is the HALT technique that is the Stellest glasses by Essilor. We have the diffusion optics technology DOT by Essilor, and the cylindrical annular refractive element CARE by Zeiss. So let me explain each of them. The first comes the defocus incorporated multiple segments DIMS by Hoya. So you can see the central zone is 9 millimeter in diameter, and that is for the distance refractive correction. The child will see perfectly through that. Around that, you can see like a honeycomb appearance of 400 multiple defocus segments. These are 33 millimeters in diameter surrounding the central zone. And if you take the magnification of each of this, you will notice that one of them is 1.03 millimeters in diameter, and they are 3.5 diopter myopic defocus. So this together will prevent the myopia, the hyperopic defocus, cancel it out, and you get a myopic defocus. This is how the DIMS works. Then the highly aspheric lenslets, or HALT, wherein you can see that they have 11 rings, as you can see. Each ring is actually one lenslet, and together this causes a hyperopic defocus volume, and this prevents the myopia, induces the myopic defocus and helps the progression from happening. Then comes the diffusion optics technology. Now we are aware that there's abnormal interaction between any two cones causes the myopia to elongate by causing axial elongation. So what this actually does, is it induces, causes an alteration between these particular dots and induces an increased glare, and that is the technology which is a diffusion optics technology which is introduced by Essilor, and that can also prevent the myopia from progressing. And finally, the cylindrical annular refractive element care by Zeiss, where you can see these multiple cylinders. These cause high order aberrations, and they induce the myopic defocus. So you have segments of normal zone and myopic defocus zones together in form of rings which go from center to the periphery. These are put on the front surface, and this is the concept with which the myopia progression can be prevented by cancelling the hyperopic defocus and inducing the myopic defocus. Thus, we have these 4 spectacle options, of which the defocus glasses are there in the DIMS, the HALT by Essilor, that is the Stellest, and the CARE. Whereas the alteration of the contrast is done by the DOT technology. Now we'll come a little bit quick on the terms that we are aware that whatever DIMS or HALS has been done in Chinese population has shown that it can slow up progression to about 60 to 70%. Still not available, but recently we have started collecting data. It's a multi-centric trial which is done all over, initiated by AIIMS, where we are getting the data from all the people who are using these defocus glasses by Stellest, and we'll soon be able to give you the data of how the Indian population is doing. A quick thing on the contact lens, because we have Dr. Meena talking, but that when you're looking at contact lenses, we are talking at 2 options. One is a night wear contact lenses, which alters the shape when the patient sleeps with the contact lenses, and best suited for those who don't want to wear anything in the morning. So the advantage is they sleep with the contact lens, but morning they're off any refractive correction, whether it's glasses, contact lens, or anything. And then the other one is a soft CL, again the same concept of cancelling the hyperopic defocus. These are the daytime wear contact lenses. Now looking at the specification, we should be aware that we cannot give it to all. There's a limit to the power that you can give. So it is seen that up to DIMS and ortho-K, -10 diopter of spherical refraction equivalent can be given, and maximum -4, but Stellest has come with -12, which is the overall one which we can consider for those with slightly higher myopia. So optical correction, therefore, to induce myopic defocus are the DIMS, HALT, CARE, ortho-K, and the soft lenses. Now, since we have multiple treatments, our long-term studies in India are still awaited, and we are short to probably for the next AIS one in Delhi, we'll be able to give you our data of how the Stellest is doing. But one thing which I want to know is how do you prescribe? Now, incidentally, we have done a study where we had 228 eyes, and we studied how these patients with myopic progression do. And we were able to show that in spite, we believe that is the peripheral hyperopic defocus that causes myopic progression, but we were able to show that about 54% had myopic defocus, unlike 46, since that means in spite of them progressing, they are still having myopic defocus. And in that, what we noticed is that we had more of nasal progression of myopic defocus, and hyperopic was more temporally. This is just a data to show. So what we do is normally, if we have a myopic or we have a patient who's progressing, we do the peripheral refraction, and we are able to show. So if it's a myopic defocus, we know that in those cases, the glasses may not really do well. So we started them on LGA. So this is our data where we had patients with 122 having myopic defocus. We gave them glasses, with LGA, and some who insisted on glasses were given as well. In those we had hyperopic defocus, we give the option of defocus glasses to them because we know that it'll work better. And in this is the data, what we have done. So basically what we do is, depending on what we have, if we show there's a hyperopic defocus, yes, we go for this option. And remember, you don't need to have a very high instrument like what we had. Any patient who has a retinoscopy, make him fixate at a distance target, give him multiple targets so that he looks at the side and you're able to pick up your peripheral defocus or not. So this is how you can calculate if you are able to show yes. Otherwise, you definitely have, but when you are able to show that he is progressing for more than 0.5, please give him a treatment option. Definitely watch him every 6 months for his axial length and his refraction, and don't forget to tell him about the lifestyle modifications. That is important. And I just want to add that SPOCI and NTOD have got this option of the National Myopia Week, where they want to increase the awareness between 14th to 20th. And therefore, anybody who wants to become part, because we need to spread this word, we don't want myopia, we want to stop it from progressing, is where you can officially send your data and get the details. So thank you very much for your patient listening, and I can take questions now.
From the audience, please.
Shell.
Excellent talk. I just had one question that we've heard about peripheral refraction. So do you recommend it in the undilated
Yes.
state, or would you have?
Yes.
Do you then compare the central peripheral refraction also after cycloplegia and then take a decision, or it's only based on the undilated?
No, it's absolutely based on undilated, because when you do dilated, sometimes your optometrist may not be able to figure out, because your pupil gets completely dilated. Ideally is to be done in undilated state, and anything more than 0.75, which is from your center, is what we would consider as a hyperopic defocus, and then look at it as in terms of progression. Also, when we're talking of this is what the patient has. But sometimes when you're giving high myopic glasses, the glasses per se induce a hyperopic this defocus. So in those cases, anything more than 3.54, I also do the peripheral refraction with the glass on and try to see if it is there. So in this case, even if the patient does not have a hyperopic defocus, but I know his spectacles will induce it, I can give them as this option as well.
And would you also try and study the accommodation lag?
Yes.
Because I've listened to lectures where they say that based on that you decide whether you give this kind of classes, or if there's an accommodation lag, progressives, or there may be a better option.
Yeah, so what I'm talking about, patients who are perfectly fine. So when there is an accommodative lag, then the treatment will not be giving this. You would tackle it, you treat the accommodation issues, and then as a subsequent. So these are patients who are otherwise normal in terms of their orthoptic evaluation.
See, accommodation problems with accommodation lag is a different thing. You know, in children, do you think there is an accommodative anomalies? There are 4 types of accommodative anomalies in children. In my book, I have said that, you know, so accommodation lag and defocus, accommodation infacility, you know, that's a different treatment. There's nothing to do with this. And the one thing, the problem with these disc lenses, that is the defocus lenses, is that the cost. It is about 15 to 16,000 rupees, and it has to change every year. That is one big problem when you prescribe these lenses. Contact lenses are even more costlier. So that cost factor has to be still. Suma, you must be also knowing about that. The cost factor is a big problem. Yes, sir.
Yes, Malik sir.
Would there be time that all refractive surgeons would throw away their glasses and have the eyes like me, which is 6 by 5 and 5?
And the last we have Dr. Meena Kharat.
Any question? Okay. So now I will invite Dr. Meena Kharat, and she is going to speak to us upon the contact lenses and orthokeratology. Dr. Meena.
Good morning, everyone. I thank Dr. Namrata and AIOC team for inviting me here today, and also Dr. Lahane, Dr. Shukla, and Jyoti ma'am. Jyoti ma'am, you have already spoken about this spectacle, so I will not go into that details. We already know it is epidemic, almost pandemic now. Myopia is a problem. We know when the parent are myopic, there's 2-fold risk, and both parents myopic, obviously there's a 5-fold risk. Asian descent will have more risk. And if you have a high-fat diet, a sedentary lifestyle, lack of outdoor play, and more screen time, patients are more prone to myopia progression. So myopia and orthokeratology have already been studied by many countries, and there are many papers which suggest that orthokeratology is one of the mechanism and remedy for myopia control. Okay, so again, there are so many papers about it. So myopia we already know, so I won't go into more details why it is so important problem these days. And there are many strategies. We have pharmacological, optical, spectacle, contact lenses, and obviously the lifestyle. So just normal, whatever GP contact lenses we give, they are not suitable remedy for it. And there is no evidence that it corrects it. But multifocal soft contact lenses are the current multifocal contact lenses that we have, they are usually for presbyopic patient what we use, they are center near designs. They are not suitable for myopia progression control. What we need is a center distance design. So the central is distance and then the periphery is a ring of a near, and then again center and again distant and near. So those lenses are important. So MySight is the only lens currently by FDA which they have said is important for myopia progression. Another one is a SEED, which is a EDOF lens. And currently there is an LV Prasad, there is a study going on where they are using the 2 weekly disposable SEED lenses, which are also giving us good results with center distance design of soft multifocals. Okay. So we already know that when we give normal glasses, it will cause the peripheral hyperopic defocus, and all these lenses, what we have to give is cause the peripheral myopic defocus, so that it will correct, that it will ask the, it will not give the signal for the eyeball to grow. That is the principle behind all this contact lens correction. So corneal reshaping of contact lenses is basically the orthokeratology is very important, and that is in studies they have shown that about 52% reduction in axial elongation has been seen. So ortho means straight keratis cornea, and ology is orthokeratology, basically it's a knowledge. So this is basically technique developed by a person who have seen that it causes a improved centration. Once the centration is good, then it causes the flattening of the cornea in the center, and in the periphery, in the mid periphery, it causes the hyperopic defocus. So central cornea is flattened by about 0.3 to 0.5 mm. Then the flattest cape. Then it depends on the corneal sill, obviously, and if the sill is too much, then we don't use orthokeratology, or we'll have to use special lenses for that. Okay. Then the steep periphery will aid in the tear exchange and centration, and larger total diameter will be required for the good centration. So this is the effect. These lenses are reverse geometry lenses. So in the center they are flattened, and in mid periphery they are steepened, so that they cause this treatment zone which is in the center. Now how much should be the treatment zone, that will again depend on each patient and the myopia. So we already know how much is the epithelium, Bowman stroma. So this treatment is basically only for the epithelium. We are not playing with stroma or descemeents or endothelium. So anything goes beyond epithelium, then this is not the treatment that we want to do. So how much area that we are going to flatten? So that is the change in the corneal sagittal height, which will be equal to the treatment zone diameter square to the desired dioptric change. So if we want 1 diopter effect over a 6 millimeter zone, then we have to flatten 12 micron of corneal tissue. So that will be redistributed. So it is something like when you press on something, it is going to bulge somewhere, right? So you are not going to take that part out, like in LASIK. It's going to be just pressed. So it's going to bulge out. So we have to give that, the reverse zone in that, so that they are steeper and the tissue will be redistributed in that area. So this is how it looks. So you're pressing in the center, and in the periphery, you can see the tissue is like redistributed over there. So that will cause the hyperopic defocus. So on the topography, you can see the central part will be flattened and mid periphery will be steepened. Now this has to be in the pupillary area, within the pupillary area. If this area, the steepened area, falls outside the pupillary area, then it is not for myopia progression. Then it is for myopia, it's a management. Like if a person like a 20-year-old or a 25-year-old do not want to wear glasses, we can still give him orthokeratology, but that is not, this zone will be bigger. So we don't have to keep this steepened zone within the pupillary area. We will only keep it in pupillary area when we are talking about the myopia progression control. So if you take before and after and we take the difference map, this is how we will see it. So not all patients are suitable for ortho-K. Like older patients who are wearing contact lenses for longer time, the cornea which are less likely to respond well, patients who have unrealistic expectations, against the rule astigmatism, and low sphere power with high cylinder, and limbus to limbus astigmatism, all these patients are not suitable for ortho-K. So corneal topographer is must. You have to measure the axial length, precision fitting has to be there, and significant rigid contact lens fitting experience has to be there. And you have a large set of special OK lenses, which is again expensive, you have to invest into. Nowadays, we can just give the K readings to the laboratory and the treatment, how much myopia we want to control, we tell them. And we don't need any fitting set. And the laboratory will send you the lenses. Sometimes we just do it on the topographical data, and contact lens fitting softwares are available. We can just do a trial contact lens fitting based on that, ordered directly from the laboratory. Or you can have the fitting set where you have up to 100 to 140 contact lenses with you and you try different contact lenses on your patient. So this is the ideal fluorescent pattern you see with central flattening and mid-peripheral pooling of the fluorescent. The same diagram schematically. So ideal fitting pattern should be 3 to 4.5 millimeter of central corneal bearing, wide, deep tear reservoir around the central bearing zone, good lateral centration, okay, so pupil coverage, good vision. So patient has to be, when he is waking up in the morning, there is no need to wear glasses or contact lenses throughout the day. So if you just say the treatment zone, we want to keep the same, say about 20 micron. Then the treatment diameter, the zone diameter, if you just compare that, if you have the bigger diameter, then you are just reducing only 1.75 diopter. But if you reduce the treatment zone diopter, you can correct up to -6 diopter. And here again same thing, if you want a reduction of -3, then if you keep the treatment zone only 3 millimeter, then you have to displace only 9 micron. Where if your treatment zone is bigger, say 7 millimeters, then you have to displace more, about 49 microns. So you have to choose accordingly. The same one, if you want expected change of 1 diopter in a smaller treatment zone, you have to depress a lesser of corneal tissue. So this is an older study which they said that maximum up to -4 are very well treated by ortho-K. And you have to review them. I mean, first night when they wake up in the morning after all night wear, you have to see them first thing in the morning along with the lenses on. Okay? And then you see whether it is, what is their vision, what is slit lamp examination, how well they are fitting, how, then you do the retinoscopy and measure the topography. Follow-up visits are also important. So first day following, then you do all the studies that we have done. And then you have to do follow-up visit in 7 to 10 days, allows full treatment to take effect, then repeat assessment. And if it's not acceptable, then you have to modify the design. Again, you have to redo the same thing what you have done. So you have to, once you have corrected the myopia, whatever desired, then you give them the retainer contact lenses. Again, care and requirement is very important. You have follow-up visits are very important, weekly, monthly, 3 monthly, 6 monthly, and 6 monthly thereafter.
We'll have to sum up, Dr.
Yeah,
Meena.
sure. And basically take care of the contact lenses as well, all the different. Now, this is just to give you advantage of orthokeratology over refractive surgery, because refractive surgery you cannot do it in children. And ortho-K you can do it, reversible, it is a reversible process, so when you stop wearing contact lenses, it will come back to where you started. So it may slow the myopia progression, and disadvantages, it's not a permanent solution. So when you stop it, you come back to where you started basically. So everything you have to remember is it needs attention definitely, but you do not scare your patients. Nowadays, in the myopia, so much we talk, sometimes patients and parents are so scared and they Google it on and they said, okay, I'm going to go blind. I mean, I have seen 2-3 patients who have come to me with -8 and now they are saying, will I go blind? This thing will happen to me. So you have to counsel that also. Don't scare them away. So choose your patients widely and give them best possible solution. Lifestyle modifications are important. Atropine, of course, spectacles, soft contact lenses, ortho-K, choice is yours. So tailor it as per your patient's need. That's all I would say. Okay, thank you very much.
Right. Thank you very much. I think it was very good thing, Meena. Questions from the audience? Yes.
Actually, I had a personal experience. One of my nieces was wearing these ortho-K lenses.
Okay.
In the morning, absolutely fine, moving around and everything. But by evening, she was just making the pinhole of the eyes. And by late night, around 10 to 11 p.m., she was almost, totally dependent because she was not having her spectacles also, and with ortho-K lenses, after evening, it was very difficult for her to manage the thing. So, how to go about it?
See, what happens is ortho-K is actually only give you effect up to say 8 hours. 6 to 8 hours, depending on the prescription, age of the patient, how much molding you have done. Okay? So you have to give them backup glasses. So towards the end of the day, they will not probably, suppose she is -3. She will not require full -3. She may require -2 or -1. You will have to do that refraction in the evening and see what she wants, what is her prescription after say 8 hours. So there has to be backup spectacle. In that case.
It's not actually that you are actually keeping the patient away from glasses. You have to keep them with the glasses.
Yeah. So, but 8 hours, I would say, it's definitely their working hours. They can. Yeah. But evening, yes, they will have to.
Yeah, see, this is a big problem with ortho-K lenses, because you're wearing it for night, and you remove it in the morning, and you say, the company says the patient is, has good 6/6 vision for whole day, but that is not the case. See, as you are saying, so that's a big number one. Number two, you're removing these lenses in the day. That is the time when the people are actually working. You see, where is the effect of myopia is gone. When you are sleeping, there's no. So now that the problem is that they are saying that it is more for management of myopia rather than controlling the progression of myopia. So when you give these lenses to a patient, you have to make them clear, counsel them correctly that we are not guaranteeing you that we will control myopia. And the other problem, what you said, is there.
Yeah. Atropine plus orthokeratology is better solution.
Yeah,
Just
the cost is also
combination.
Any
definitely
other questions?
costly.
Any other question? Okay. I
just
think
5 minutes more, so you can have anything.
I think the yes.
Sure.
I would like to ask a question to Dr. Suma. This atropine eye drops that we use, is it purely for myopic, spherical power, or it can be given for astigmatism?
In that, Suma,
You can
speak in the speaker.
You have a हाथ वाला नहीं है?
Yes.
A good point you did. Most of the patients, sometimes I'm seeing people even when there is astigmatism number, they are prescribing atropine eye drops. It does not work for astigmatism. It is mainly we are trying to halt the progression by working on the vision. So it is a different combination. Yeah, if there is a progression in myopia and along with it there is astigmatism, yes. But parents do ask that whether the astigmatism, because you give LDA suppose, next time the child presenting with the increase in pupil count, then they ask to make a dawai dal rahe, then you have to tell them that it does not work on this cylindrical power. So basically they are trying to follow the progression of myopia only, not only cylindrical.
You see, how much astigmatism do you expect? 5, 6, 7? No. See, normally the astigmatism doesn't go more than 3 or 4 in any case, More than 6 it goes, then you have to think of keratoconus or something else. So for that, just one astigmatism, whether it is meridional or whether it is, the normal one, you don't give atropine. It's not a work for that because that is a corneal astigmatism. See, because that is due to cornea, not axial length. So,
But I think one caution is that like we have started doing is that whenever any, when they are progressing, the myopia also is progressing, we are getting a pentacam done because we can have, there are reviews, there are papers which are saying that higher the myopia the patients can have, the progressing is much more, they can also have keratoconus. So it is important for us to check that also.
yeah, that of course, it's very rare that you have both together, the corneal myopia as well as, the axial myopia. Normally, the genetic what we have is for axial myopia. Corneal is very limited, but rarely it can, combine together. For that, then you have to look for the axial myopia progressing. Any question?
One more point I want to say that when you're talking about tapering of myopia, yeah, we say it as a standard 2 years, but when you're deciding to do it, ensure that at least for about 6 to 8 months, your axial length is not progressed, your refractive error remains stable, and only. Also remember in children, the puberty is a time when it can shoot up. There's a growth spurt. So you confirm with the parents that yes, the patient has attained the puberty, and boys it comes later. So many a times, unlike the the other Asian studies where people have spoken about till 6 to 12 years, in Indian population we have had to give up to 14 and A16 years. So watch these things. So every time you decide to take off your atropine, be sure that is off, the refractive error is not changed, your axial length is stable, it's not increased, and a patient has attained the puberty. And the lifestyle also is like he's taking those breaks, he's doing it, so that you know that when you're taking it off, it's not going to come back as a rebound. So that is what you have to watch. So it's like individualized. You cannot say like, everybody, but try to understand each patient, each family. Like you may have a family where both parents are high myopes, brother is high myope, and this child is already progressing. He's a voracious reader. So there are a lot of things that come in. He doesn't go out to play. So there are a lot of things. So you have to look at the whole picture as a whole and then decide what to do with each of them.
I think, thank you very much. Thank you, Shukla sir. Thank you, Jyoti. Thank you, Meena. I will request Meena to come on the dais for the photograph. Also, if the entire people are there, so they can come for the photograph. Sir, for the photo.
It's an entered representative here.
आगे आइए आगे मैडम ऊपर आइए.
There is a workshop on orthokeratology at 2 o'clock in DSTC area. Anybody wants to attend?